If you've dislocated your shoulder, you probably want to know one thing. Is it going to happen again? The honest answer is, it depends. And understanding what it depends on is the most important thing you can know about shoulder instability. The shoulder is the most mobile joint in the body. That mobility comes at a cost. The socket, the glenoid, is deliberately shallow. It's designed for range of movement, not for containment. What compensates for the shallow socket is the labrum, a ring of cartilage around the rim that deepens the socket and anchors the ligaments that hold the joint together. When the shoulder dislocates, the labrum is almost always torn, and that changes everything. Most shoulder dislocations are anterior. The ball comes out of the front of the socket. This typically tears the labrum from the front of the glenoid. We call this a Bankart lesion. The force of the dislocation can also dent the back of the ball itself, a Hill-Sachs lesion. These aren't sprains, they are structural injuries. The joint that goes back into place after a dislocation is not the same joint that came out. The labrum doesn't reliably heal back into position on its own. So when a young person returns to rugby or contact sport after a course of physio, they're loading a joint that has lost its main stabilizer. Recurrence rates in young athletes managed conservatively, sling, then physio, are reported as high as 70 to 90%. Age and activity level are the strongest predictors. The older you are and the less demanding your activities, the lower your risk of redislocation. Diagnosis starts with the history and examination. For imaging, your GP or physiotherapist can request a shoulder X-ray. It's important to include an auxiliary view, not just the AP, as this gives information about the bony architecture of the joint. An MRI arthrogram, where contrast is injected into the joint before the scan, is the most accurate investigation for the labrum. In New Zealand, this is arranged through the specialist after referral. In patients over 40, a first dislocation is more likely to involve a rotator cuff tear than labral damage, so imaging in this group is particularly important. After a first dislocation, the standard starting point is a sling followed by a structured physiotherapy program. Physio focuses on rebuilding the strength and dynamic control of the muscles around the joint. For many patients, particularly those who are older or less active, this is sufficient, and surgery is not needed. Surgery is considered when the shoulder keeps dislocating despite physiotherapy, or in select high-risk cases. The main surgical option for most patients is a Bankart repair, an arthroscopic keyhole procedure that reattaches the torn labrum using small anchors. Where there is a significant Hill-Sachs lesion, a Remplissage procedure can be added in the same session. When there is significant bone loss from the socket itself, a Latarjet procedure is used instead, a bone block transfer that rebuilds the front of the glenoid. This is an open procedure used in specific circumstances. Recovery after surgery involves a sling for 4 to 6 weeks with physiotherapy throughout. Return to contact sport is typically at 6 to 7 months. If you've had a shoulder dislocation and want to understand your options, a GP or physiotherapy referral is the right first step. I've linked a full patient guide in the description below.